Madam, I have connected everywhere. You can start the meeting and please record the meeting. Varsha madam.
Recording in progress.
Hello everyone. Good evening.
Good evening.
Good evening.
Good evening. Good evening.
Good evening, Kirti. Hello, Dr. Joy. Good to see
Good
you.
evening,
after a long
Varshali.
time. Good evening.
Good evening, Varshali.
Good evening. Hello, Dr. Rajeev.
Hello, ma'am. Good evening.
Dr. Harshe.
Good evening, madam.
Welcome to SSPP.
Thank you. Hope I am audible.
Yes, sir, you are audible.
Yeah, thank you. I'm muting it right now, right?
Yeah, yeah.
Varsha ma'am, you can start the meeting.
I'm not able to see Varsha. Oh, right, in the middle. Hi. आवाज नाही आला तुझा.
Okay, so good evening everyone. And now we are starting this meeting, which is monthly academic activity by Society for Study of Pain PUNE. And we are starting today on the theme of needling in chronic pain management. So now I welcome our president, Dr. Jana, to start the meeting. Welcome, Joy, sir.
Thank you, Varsha. On behalf of the Society of Study of Pain Pune, I welcome you all. Can you change the screen to me? Rahul?
Yes, sir.
Yeah. Put me on the screen.
Yes, sir. It is on speaker view now from my side. The one who has started recording, please make it on a speaker view.
What are you recording?
And I request everyone, Dr. Ashok, can you go on mute, please?
Excellent.
Yeah.
अच्छा बेटा आपका एनर्जी फील करें.
Yes, Rahul. Put me on the screen.
Okay, sir. Sir, you are visible on full screen.
I know I'm not on the screen.
Sir, you are visible to us. Varshali ma'am, can you see him? We are able to see you. Yes, sir.
Dr. Jana, we can see you.
Yeah, please go ahead with the screen, full screen.
It is full screen, sir.
Yeah,
सबसे पहले पानी पीना बेटा.
Somebody is
See you, Dr. Jana. We can
is
start.
not unmute.
Yeah, I have muted him.
Yeah. So on behalf of Society of Study of Pain Pune, I welcome all the delegates and our faculty for this first Zoom meeting on today's topic. We had the first hybrid on craniofacial pain last month in the month of June, and after in the month of May we took it as office bearers. So we started this first Zoom meeting. As our principals, we invited our first guest speaker, Dr. Rajeev Harshe, Dr. Rajeev Harshe, welcome. Thank you so much for Rajeev. Thank you so much for joining us here on Zoom.
My pleasure.
And yes,
Thank you.
Rajeev, thank you, sir. And we always encourage our SSPP members to present along with our faculty members who is presenting today. First is Priya Rathi and Dr. Kailash Waghmare. Kailash has had a grudge that I have never been allowed to speak in our SSPP. Kailash, can you hear? This is the first meeting with our, as taking over as the president, I'm allowing you the first time to allow you to speak. So, though he is now settled in Solapur, though he's associated, and I'm glad that he's associated with Pune. Thank you, Kailash, sir, that you have joined with us to present your all your presentations. And since then, we are starting now. Every month, we'll be presenting the various clinical meetings in chronic pain. And now I invite our moderator, Dr. Kirti Pawar. Kirti, you are online already, and I'd like to welcome you for this clinical meeting. Kirti is already not only a state or national, she is an international faculty. She has won so many awards. You can go through this slide. Fantastic. I mean, we are proud that you are a member of Pune Society of Pain Pune. So she's our moderator for today's presentation, and I hand it over to Dr. Kirti to take the proceedings forward. Kirti, please take it forward.
Kirti ma'am, you have to unmute yourself. Acha, maybe that setting I did. I will unmute you. Okay, did you get the prompt to unmute? Yeah.
Thank you. First of all, I would like to acknowledge my gratitude and thanks towards SSPP for giving me this privilege. We all know that chronic pain is like a jigsaw puzzle. Orthopedicians, rheumatologists, pain physicians, neurologists, and physiotherapists all are trying to join pieces of this chronic pain puzzle. Everyone will be agree with me that there are high number of patients suffering from chronic pain and not able to receive sustainable and one-stop solution to their chronic pain. I think this is high time to understand that chronic pain is not all about joints, bones, and nerves. Muscles are pain expressors and real sufferers. Ultrasound-guided dry needling is gaining high popularity in radiology and rheumatology. So friends, let's expand the horizon of pain management by initiating the topic of discussion, needling in chronic pain. And I'm really honored to invite our first speaker, Dr. Rajeev Harshe. He's an eminent pain consultant from Ahmedabad. He's a pain consultant to His Excellency Governor of Gujarat, Director of Relief Pain Clinic Gujarat, Director Dr. Harshe Pain Academy, and pain consultant since 2004. He is a faculty in national and international conferences on pain and author of a book on pain. I invite Dr. Rajeev. Over to Rajeev, sir.
Rajeev sir, you can share the screen.
Hello, is it okay now? Can you see the screen?
Yes, sir. Screen is visible and full screen.
And I'm audible?
Yes, sir.
Okay. I saw the video so that I can concentrate more on the topic, right? Okay. Thank you very much, madam, for inviting me in this first of your online meetings. And regarding the introduction you gave, one small rectification. I have just contributed a chapter in a book. I am not that that great that I can write a book. But well, thank you very much for all your kind words. And so we begin the topic, first topic, and that is hypodermic needling, a novel treatment. Right. Now, a moment, why it is not scrolling down? Yeah. Okay.
We can see the next slide, sir.
Correct. Yeah, I was having some problem here. Okay. So the thing is, what is hypodermic needling? Most of the people who must be listening, for them this was a new thing. Yes, because it is something which I coined over a period of time, and it involves inserting routine injection needle, 26 number half gauge hypodermic injection needle used for neonates. This needle I use, and it is inserted hypodermically in defined spots of the body to manage pain. Now, the question is, by putting a small needle under the skin, how is it going to work? It works on the principle of gate control theory of pain, and as the PPT will unfold, you will understand how it works. But in a nutshell, it works on the principle of gate control theory of pain. Now, 15 to 20 minutes was a little tight time to speak in detail. So I have touched the common things, and that is the basic one slide tells you a lot about the pain pathway, right? If you see the pain pathway, it starts from a nociceptor in the periphery, which when stimulated, stimulates the afferent nerve fiber, which then relays in the dorsal horn of the spinal cord, from where the second order neuron begins, and it goes to the thalamus. From here, the third order neuron goes to the cortex, and we know all about it, right? And there is something called descending inhibitory pathway, which has an important role to play. We know about various types of nerve fibers, C, A delta, and A beta being the most commonly discussed and most commonly useful one. Now, the important thing here is, now C and A delta, they are the main contributors in the terms of transmitting pain from the periphery to the center. And A beta has little different role to play. If you see this slide, which I have taken, I'll acknowledge the Alia medical media, which I have extracted from YouTube. This was a beautiful picture which could explain a lot of things in a simple picture. If you see here, the blue one which you can see is the A beta fiber. Now, when these A beta fibers are stimulated, they stimulate an inhibitory interneuron in the dorsal horn. And this inhibitory interneuron then inhibits the conduction from first order neuron to the second order neuron, reducing the influx of the pain. This is what we learn as gate control theory of pain. So now this A beta fiber has tremendous role to play in controlling the pain. Otherwise, when stimulated, there will be constant barrage of impulses coming up, and a level will come which will be intolerable. But this controls the influx. Now, when this interneuron is stimulated, it also, the descending inhibitory pathway, and this releases endorphins and enkephalins in the dorsal horn. And these endorphins have a lot to do. They again contribute in inhibiting the action potential, right? And they are also commonly seen to be released in the pleasurable activities like excitement, meditation, laughter, vigorous exercise, and we all know the importance of endorphin, right? As I said previously, the spatial interneurons in dorsal column of the spinal cord, which is the yellow one you can see here, when stimulated, control the influx of pain impulses and release endorphin and enkephalin, which in turn improves the pain control better. We know that the existing modality like TENS and spinal cord stimulator use this concept, right? Then why should I think of this new modality? Well, what I thought, I may be wrong, but this is what I thought, and this is how I went ahead. That the spinal cord stimulator works quite deep in the spinal cord, right? And exactly at the point where it has to act. But it's too costly for routine use in India, especially in India, right? Where insurance is not so easily available. Then procedure is definitely high end and may need constant vigilance and follow-ups, which in our scenario is little difficult, especially when we talk about the village patients, right? TENS works by superficial approach. It works well, but consistent results are not seen in the market, maybe due to various reasons, which include diverse protocol and so and so. So I thought, why not find something intermediate, not too deep, not too superficial, and can I do something about it? Because ultimately I know that it is the A beta which is my helper, and I have to stimulate the A beta. So next step I followed was, why not stimulate A beta fibers peripherally, which are stimulated centrally by spinal cord stimulator. So I tried to study where are their peripheral ends, and when I saw it, they are below the skin and above the muscle. So this picture tells you the whole story. This is the A beta fiber, right? Just under the skin. They are also called proprioceptive fibers. You must have seen in your routine life that whenever there is a pain in some part, if you just move your hand over that part, very likely you feel better. Or somebody presses that part, you feel better. Probably this is the stimulation of A beta fiber, which probably gives you relief. So these two arrows tell you where are these A beta fibers. So I thought, again, one very important thing I would like to share, and I would like all listeners, if they are not reading, please go through this book, Acupuncture, Trigger Points and Musculoskeletal Pain by Baldry. What a fantastic book he has written, and he has told a lot about the trigger points and how if you deactivate these trigger points, then pain is released. So I was more or less, reading this book, and then I thought that combining these two, can I put needle under the skin and see? And the first patient of hypodermic needling was myself. I had myofascial chest pain after yogasana, which I did over enthusiastically. And that pain was not relieved by analgesic for a couple of days. I got everything done and everything was normal. So then I thought, let me do it. And to my surprise, the very next day, I was completely pain-free. Even the same thing I have experienced 2 months back, after 12 years, 10 years of my practice of hypodermic needling. I had dental extraction and the last molar, and after that, the pain was severe. So I took all analgesics and antibiotics, blah, blah. I thought 5 days, maybe 7 days, maybe 10 days, pain should go. But it was not going. And the dentist had pulled my head on one side and did the job. So even my neck muscles were pulled. So I used my hypodermic needling. I put needles right over the jaw, in the sternomastoid, above the sternomastoid, and in the neck muscles behind, which my wife helped to do. And you will not believe. Next day, my pain was gone. And 30 days down the line, I don't have that pain now. So this is what I have experienced. Then the journey started. So I started doing needling first on relatives, naturally. Nobody would believe. People might feel that you are doing something new, which is maybe nonsense. Then close patients who were having faith in me. And then I started offering all because it was giving good results. But my prize patient, from where I decided, no, I have to take it to the next level and to the patients, is that in 2012, in Apollo, I was referred a patient from an orthopedic surgeon who had severe back and leg pain. He had undergone 3 spine surgeries. 1 spine surgery, then redo, and then infection, so third. And then some pain consultant had sincerely tried 7 different blocks consecutively without a single result. Now, patient was very poor and she was exhausted monetarily, mentally. So I explained her, see, I do this. If you want, I can help you. She was on all possible medications. And you will not believe, she had complete pain relief in 3 sessions. Not only that, she joined the job. Her brother-in-law had a shop of agarbatti and she used to sit and sell it. She started doing that. This stimulated me to do further and further work. So I started using it in different pain situations. By now, it's 9 years, more than 10,000 patients, and many of them have got good results. I don't want to say that this is a magic wand and you can treat anything and everything. No. In certain high-end patients, this does not work. Probably I may be at fault. I may not be able to understand the pain properly or understand the source properly. That might be the reason. Or the phenomena itself may be weak enough to not address a high-end kind of case, right? I published one case report, coccydynia, hypodermic needling in coccydynia, and soon people started taking interest in it. As of now, I have treated patients of discogenic pain, perceptogenic pain, vertebrogenic pain, yes, vertebrogenic pain, myofascial pain, osteoarthritis pain, plantar fasciitis or other heel pain, tennis elbow, periarthritic shoulder, 2 patients in CRPS as well, post-surgical pains. Again, I say, do I mean to say that I can treat all patients? This is magic wand or I'm great? No. What I want to emphasize is this is a useful modality, really giving excellent results in number of patients, and this needs further and further study, further and further usage to give us feedback as to how we can modify and improvise on this so that a lot of patients can be helped who are poor. Do we think it can replace all existing treatment? Not at all. I have done yesterday only 2 image guided procedures, 1 ultrasound guided procedures. Why? Because A, some of them never opted for this. 2, some of them were not ready that this new treatment, I don't know how it is going to work. And 1, when he got it done, he said, ठीक है, मुझे थोड़ा जल्दी है, आप तो injection लगा दो. So there are a lot of factors in practice which help us or do not help us in taking a particular modality further. But I tell you, it really works in number of patients, many of them. So what I think now is, and I think all our learned audience would like to scratch head is, we look into the change in anatomy as reason of pain, but it may not be showing all. Change in physiology, which is a well-known concept, we know hypersensitization, right? Hypersensitization may be the root cause in many. And that is why some people just give repetitive plain local anesthetic block and patient get better. We have seen and we have heard Dr. Gore giving plain local in the periphery, calling it sodium channel gate block, and even I use it day in and out. I today gave itself to my neighbor's wife, excellent result. Why it works? Probably we are tackling a change in physiology rather than change in anatomy. And when the change in anatomy is dominant, probably this may not be working. Now, points of insertion. When I am talking of points of insertion, I'm sorry, I may not be detailed and elaborate in showing you how I do it in every patient because time is short. Second, I have noticed that when people listen and try to go and do it, probably they may not be able to completely implement my philosophy. And that is why they may not get results. And then this modality may lose interest in the minds of pain consultant. So I'm telling you my brief idea as to how I do it. First is proper diagnosis of source of pain is must. This is the first thing, whether it is particular disc, particular facet, or combined, or muscle, whatever. Second thing is to consider its dermatome coverage. And third thing I see is other active trigger points as well. There will be secondary trigger points. Many times I used to do only dermatomal and I never used to get result. Then I started adding trigger points and I started getting results. So I am also improvising on that. But I have seen excellent results with this new modality. See, this is the kind of needle I put. You can see this is a simple half-inch 26 gauge hypodermic needle and see how flat it is. Like the way we take the vein, it is not perpendicular. It is not perpendicular. As we do it in dry needling for inserting in the muscle, this is not at all perpendicular to the skin. I just go beneath the skin and I put it, right? Briefly, I am not here to do propaganda, but I am here to try and tell you how people feel. So I'll just show you one or two reviews, or you may see where you can see the reviews. I may not even show, but this will tell us this is my page, Google page, and you, here if you click, naturally you will see the reviews which all of us have. Only one I would like to show to you is our own pathologist, Dr. Sanjay Gupta. I'm a doctor of transfusion medicine. I was in bed rest with lower backache and leg pain and on pre-cab and painkillers. Dr. Harshe gave me dermatome needling. Next day, I joined my day routine activities. And this is true. I'm completely, he was down on bed for
Hello. Hello. Harshe sir left out. Am I audible?
Yes, Dr. Varsha, you are audible.
Okay. Probably he has internet breakdown.
Sir, can you call him and just inquire?
He might be just trying, so wait for a minute. Call him.
He got disconnected.
There's some charging issue with laptop. With joining back.
Screen is visible. Someone please reply. Screen is visible.
Yes, Dr. Varsha, it's visible.
Okay. So Harshe sir is joining soon. I have shared the screen.
Yes, sorry, there was some technical snag.
Yes, sir. Please go on.
Am I audible?
Yes, you are audible. Should I go to next slide? Or?
Just a moment.
Yeah.
No, I'll do that. Let us share. I'll share it. Yeah.
Okay.
You
Disable screen sharing.
disable screen sharing.
Okay. I'll have to make you co-host. I'll have to make you co-host. Wait a minute. Okay, sir. Check now.
Why is it not happening?
Check, please. You can share the screen now.
Yeah. Okay.
Okay.
Fine. This is a small video. Doctors.
Hello, Rajeev sir. Are you speaking?
There's again problem at his end, I think.
Yeah. Hello, Dr. Rajeev. We can't hear you. Dr. Rajeev, probably your bandwidth is low, so I will share it for you. You just be on a speaker mode. That will work. Yeah, we are just waiting for half a minute. We can see you in a small frame and it's not running, I guess. It's a static picture. Am I right?
Screen केलं start now. पण this information enable करावं लागेल ना. So just go down and zoom enable करा. हे zoom back. बस झालंच share. आता
Okay. Can you see the screen, madam?
Yes, screen is visible.
This is a understanding which probably. And is the sound audible?
No, sound is not audible.
Unable to play during call. थांबा मी करू setting.
Oh, you please. अच्छा. Call चालू है का? नहीं.
नहीं Zoom call चालू है.
Anyway, madam, let me close. No problem. These are doctors' videos which probably were telling how they have experienced this particular modality. So we can go ahead with closing my PPT.
Zoom click.
Okay, sir. I will just open this particular video. It is opening in my screen. Okay, so we can listen to that.
Can you see that?
Yes, we can see that. We can hear that. If you stop sharing, I can come to that.
Okay. No, but the video may not play because it might be having a link to my computer.
No, it plays. I just checked. We'll have once. We'll have check once. Okay, is my screen visible, Priya?
Yes, Dr. Varsha, it's visible.
Video is audible?
No.
Video is not
You
audible.
have to connect.
Okay, fine. I'll tell the story. This is a dentist. Okay, thank you. No problem. Thank you.
Sir, go on with that story from your side. We'll hear it from you.
No, it's all right. I mean, let others have their own time. I have already wasted your 10 minutes in taking a snack.
No, sir, it's okay. It's okay.
Dr.
I think-
Harshe, we would like to hear the case. What
Yeah.
was her complaints and how did you treated her? In short, we
See,
would really like to hear that.
Fine. See, the first video which you saw, there were 5 or 6 videos of doctors which I have posted. The first video which you saw was basically a dentist having severe neck pain and arm pain. Actually, she had 5-6 disbulged and mild nerve compression on the right side. Now, she was already on the treatment of orthopedic surgeon since almost a month. She was wearing collar and her husband is a radiologist. So after a lot of medications also, she was not getting relief. The radiologist came to me, he said, sir, कुछ इसमें हो सकता है क्या? और एक बार लेके आए, देखते हैं क्या है. When I saw, it was more of facetal pain than actually discogenic pain. And there was a lot of trapezius spasm. So I did hypodermic needling for right-sided 5, 6 and 6, 7 facet and trapezius. I did it in 2 sessions, weekly once. And second session, she stopped using the collar. Third session, she was up and out. She started working her routine dental work. Second patient, which I have quoted, is an orthopedic surgeon. Hello, can you listen me?
Yes, we can listen to you.
Can you listen me?
Yes,
Yeah.
we can. Yeah.
Second was an orthopedic surgeon who had pain in the outer side of the thigh, and it was fitting into nothing but iliotibial tract pain. And there I did needling, and in surprisingly only 1 session he got relief, and the pain was since 2 months. Orthopedic surgeon himself, right? Third was a case of a gynecologist who had thoracic facet joint pain, for which everything was done, including RF at some place, and there was no relief. And here we did simple needling in 3 sessions, and the video at the end is concluded by that doctor, and he is so happy. Probably he has sent me more than 15 patients himself. So there are innumerable stories. I'm not here to showcase that I'm great, but I want to stress that yes, this modality has proven excellent. For those who want to really learn it, I'm planning, I might have 1-day session wherein morning 1 hour, 2 hours, I may talk about it as to how to do it. And then I'm going to have a camp, because we all know in our pain clinic, we don't have queue of patients. At least I don't have 4 or 5 or 6 or max 7, 8 patients. We're happy. But for them, I can arrange 70 to 100 patients camp wherein I can show them and they can learn. So thank you very much, madam, again, for allowing me to talk about this new concept. Thank you.
Kirti ma'am, can you address the questions and discussion?
Yeah. Thank you very much, Dr. Harshe.
Yeah.
It was very informative. And I agree with you that if you tell the procedure in this session, the people start practicing with inadequate knowledge.
Correct.
Yeah, this is the really good way of presentation, and I thank you so much. And we would like to move on to the next speaker because we are short of time, and we will take the questions.
Yes.
In
Yes. Yes, this is small letter I को ऊपर नीचे
I'll mute again everyone and give the prompt to speaker only. Okay, just bear with me. Yeah. So Kirti ma'am, can you mute yourself now? Okay. Please unmute yourself.
Hello. Yeah.
Yeah.
Can you share the screen for Priya's introduction?
Yes.
Anyways, Priya is known to everyone in Pune. She is a very eminent pain physician.
Oh, sorry. Something popped up.
Okay, I will read from my side.
Yes, we start introduction. Meanwhile, I'll share.
Priya has done her MD and DNB Anesthesiology, Fellowship in Chronic Pain Medicine, and Fellow of Indian Academy of Pain Medicine. She is a consultant pain specialist at Sigma Spine and Pain Clinic, Asian Ortho Spine Clinic, Sancheti Hospital, Golden Care Hospital, and she has published 2 research papers in international journals. It's really honor to invite Dr. Priya Rathi to deliver a talk on needling. Over to Priya.
Thank you, Dr. Kirti, for the kind introduction. I'll just share my screen. I would like to thank SSPP for giving me this opportunity to present on this very important topic, that is muscle physiology and pathophysiology of myofascial pain. So we all know that skeletal muscles comprise of nearly half of the body's weight, and it is the only organ in the body that is not linked to any of the medical specialty. So Seaman has said that muscle is an orphan organ. But let me tell you that muscle carries equal importance at any other pain generator in the body. Why I'm saying this is because muscle nociceptive afferents are effective in inducing the neuroplastic changes in the spinal dorsal horn. It activates cingulate gyrus, which mediates the emotional and affective component of the pain, and muscle pain is strongly inhibited by the descending pathways. Prolonged muscle inputs can lead to misinterpretation in the CNS, which leads to allodynia, hyperalgesia, expansion of the receptive fields. So with this, I would like to say that muscle pain is also known as fibrositis, interstitial myofibritis, myoglosis, non-articular rheumatism, myofascial pain, idiopathic myalgia, myofasciitis, perineuritis, myodysnuria, and fibromyalgia. But the term which suits us the most is myofascial pain. So going to basic history, Kellgren was the first person to describe referred pain from the muscle. These are the basic few history points, but we should know that muscle pain has been described from 16th century. Janet Travell and Rindler in 1942. Janet Travell was a cardiologist who had special interest in musculoskeletal pain, in fact, myofascial pain. So they observed that fascia generated similar referral patterns as contractile elements, so the term myofascial pain was applied, and that term is continued till now. Rindler coined the term trigger point. Simmons and Travell, they laid down the energy crisis hypothesis, which I'll be explaining in the next slide. Sigder et al. In 2008 have said that trigger points can be identified by ultrasound and sonoelastography. In ultrasound, they are seen as hypoechoic structures, and under sonoelastography, they are being seen as the stiff bands. So what is this energy crisis hypothesis? Whenever there is trauma or damage to sarcoplasmic reticulum or cell membrane, there is release of calcium into the cytoplasm. This causes activation of actin and myosin, further reducing the ATP. ATP is now required for the muscle relaxation. So once ATPs are less, it again causes impaired calcium pump, leading to increased calcium. So this vicious cycle continues. Now, what are trigger points? Trigger points are the hyperirritable spots in the skeletal muscle that are associated with hypersensitive palpable nodule in the taut band. Trigger points are associated with somatic conditions as well as visceral conditions. So what are somatic conditions can show trigger points? Almost all the somatic condition can have trigger points like radiculopathy, failed back surgery syndrome, joint dysfunction, disc pathologies, tendinosis, craniomandibular dysfunction, headache. Certain neurological pain conditions, which are considered to be purely neurological, can also have trigger points as their presentation, like carpal tunnel syndrome, trigeminal neuralgia, post-herpetic neuralgia, and complex regional pain syndrome. In visceral pain conditions, trigger points may be present in pelvic pain, dysmenorrhea, endometriosis, interstitial cystitis, irritable bowel syndrome, gallbladder and urinary bladder calculi, and prostatinemia. Just trigger points are present in all these conditions, just that in clinic we tend to overlook those trigger points. So here are certain examples of the patients wherein I treated them with ultrasound guided dry needling, considering the examination of the trigger points in these neurological pain patients. So this was the patient of trigeminal neuralgia who had presented to me with shock-like pain, and she had background constant pain also. Her mouth opening was reduced quite a bit. I did 6 to 7 sessions of dry needling for her, and this is how she had presented with. This was the picture after 3 sessions. Her mouth opening had increased quite a bit. Her pain level had reduced by 50%, and with 6 to 7 sessions, she was much better, around 80% better. So this is the patient of post-spine surgical pain. Patient had severe spasm of erector spinae, quadratus lumborum, and psoas, who improved with 6 to 7 sessions of dry needling under ultrasound. So CRPS, which is considered to be pure neurological condition, but it is in fact a tremendous spasm of the muscles along with neuropathic component in clinical setup. So this was my patient who had CRPS after 4 surgeries for his radius fracture. He presented to me with shoulder hand syndrome. His movements at wrist, elbow, and shoulder were tremendously painful and reduced. His muscles were atrophic. You can see the deltoid atrophy here. After 8 to 10 sessions of dry needling, he has improved to this much. Here 90 degree of abduction was not possible, but here it is. He is going to 180 degrees. Bulk is also regained. So now, this trigger point's existence is being confirmed by magnetic resonance elastography. These trigger points can have motor phenomenon like weakness, stiffness, restricted range of motion, disturbed motor function. It can have sensory phenomenon like allodynia, hyperalgesia, referred pain, peripheral sensitization, and central sensitization. It can have autonomic phenomenon also, like vasodilatation, vasoconstriction, lacrimation, and piloerection. Trigger points could be of 2 types, active or latent. These active trigger points are spontaneously painful, and it can have motor, sensory, and autonomic phenomenon along with it. Latent trigger points are painful only when they are palpated, plus it can have all the features like motor, sensory, and autonomic phenomenon. Now, to understand the trigger points, we need to know the basic muscle physiology. Now, each muscle cell is known as muscle fiber. So this is whole thing is muscle fiber. It is lined by sarcolemma. Inside the sarcolemma is the sarcoplasm and multiple parallelly running myofibrils. These myofibrils are interconnected. Now, the microstructure of the myofibril is like this. Functional unit of muscle is sarcomere. What is the sarcomere? Sarcomere is the part of myofibril that is present in between the Z lines. Now, these Z lines are formed by the protein called myopalladin. This myopalladin holds actin filaments parallelly, and in between the actin filaments, these thick filaments are myosin filaments. These actin and myosin filaments are held together by the protein called titin, and titin is the largest vertebrate protein. This titin forms a gel-like structure at Z line when muscle undergoes contraction. Titin forms the gel-like structure at the Z line when muscle undergoes contraction. Now, when we see under electron microscope, the part of sarcomere which contains only actin filaments is seen as a light band. So we call it I band. Then the part of sarcomere which contains actin as well as myosin is called as A band, and the part which contains only myosin is known as H zone. The length of H zone is completely obliterated when muscle contraction happens. So why this details about everything? Because it has certain clinical implications, which I'll be explaining later. Now, actin-myosin interaction happens only when this troponin-tropomyosin complex is being bound by calcium. So when calcium binds with the troponin-tropomyosin complex, these myosin heads can interact with the actin. So usually the myosin heads are like this. You can consider this to be myosin head, and the movement happens like this. So once myosin head moves, it brings the actin filament to the center of the sarcomere, and the contraction happens. So what are the implications in the myofascial pain? These MTRPs can have damaged sarcomere assembly. Myosin filaments may have broken actin-titin barrier, and myosin may have got stuck in the gel formed by sticky titin at the Z line in case of myofascial trigger points. So clinically what we see is whenever there is tremendous muscle spasm, these contractile elements of the muscle, which are seen as the red cells, are being replaced by the fibrotic tissue. Here, this is the picture wherein this is a picture of the muscle in CRPS, dramatic presentation in CRPS, wherein the contractile element is being replaced by the fibrotic elements. So under ultrasound, we can see these findings. So this is the ultrasound picture of the normal forearm, wherein we can see radius, we see ulna, and the muscles are being seen as a nice boundaries of the muscles are being seen. Normal muscles are seen as a black background against which white fibrous tissues are being seen. But in case of CRPS, the muscle bulk is reduced, as well as you can see the contractile elements are being replaced by the fibrous tissues. This is a microscopic picture of MTRP, wherein we can see this A and C pictures are the normal muscle fibers. This is a cross-sectional, this is the longitudinal view. In cross-sectional, we can see nice polygonal muscle cells, but in MTRPs, the clumping happens. Lengthwise, here parallel muscle fibers are being seen, but when in MTRPs, these are seen as inflating and tapering fibers, and there is abnormal aggregation of the muscle fibers, which shows short cracks, and there are large gaps between the muscle fibers. Here we do not see any gaps, but in MTRPs, that is myofascial trigger points, these gaps are being seen. So about neuromuscular junction. So what is this neuromuscular junction? It is the junction where nerve ending meets the motor endlet. The space between it is called as synapse. So whenever the action potential reaches the nerve fiber, it causes opening of the calcium channels at the nerve terminal. Once the calcium enters into nerve terminals, the acetylcholine is released from the nerve terminals into the synaptic vesicles. This acetylcholine binds to acetylcholine receptors, leading to influx of the sodium. This sodium, once it is into the cells, leads to depolarization and activation of the process, contraction of the muscles. So what is the implication in myofascial pain? There is spontaneous electrical activity at myofascial trigger points, and it occurs due to excess of acetylcholine at the motor end plates. Now, to understand this, we need to know the integrated trigger point hypothesis, which is the most evidence-based hypothesis right now for the myofascial pains. So, increased acetylcholine at neuromuscular junction, it leads to opening of the sodium channels in sarcoplasmic reticulum. This further leads to increased calcium release from the sarcoplasmic reticulum, which further causes persistent muscle contraction with myofascial trigger points. There is compromise of the blood vessels, leading to hypoxia and reduction of the pH, and which further causes muscle pain and dysfunction. And there is a good evidence which says that oxygen saturation in myofascial trigger points is far below the normal values. So with this, biochemical milieu of MTRPs is being well studied by Joyshankar. So what he has done is, he has invented a device called microdialysis pump. Microdialysis pump is being attached to 30 gauge hollow needle. That needle is used for the needling of the myofascial trigger point. So with the same needle, sample is being collected. Samples of the plasma for before, during, and after the needling process is being collected. So what he has found is, in myofascial trigger points, pH is low, protons, bradykinin, substance P, CGRP, TNF alpha, interleukin 1 beta, 6 and 8, 5-HT and norepinephrine are all high. So with this, I would like to go to next concept called local twitch response. Local twitch response is an involuntary reflex contraction of the muscle fibers within the taut band. It is elicited by manually strumming or needling the taut band. It can be observed visually, it can be recorded electromyographically, or it can be visualized on the ultrasound. And it is important to note here that local twitch response, when we see under ultrasound, we can see multiple local twitch responses when the muscle is needled, but all those responses are not seen visually. So for dry needling to be effective, we have to have ultrasound for the procedure. So here is a video wherein, when I am introducing the needle, patient is having a large local twitch response and a small local twitch response here. So you can see there's a good response first and the second one. The second one was not seen visually. So it is not always important to just hunt for the local twitch response whenever we are doing dry needling blindly. With this, I would like to thank you all for patient listening. Thank you.
Yeah, thank you, Priya. It was very informative. So we will move on to next speaker, Dr. Kailash, and we will take the questions in the end. It is very nice to introduce Dr. Kailash Waghmare, who is a pain physician from Sholapur. He has done MUHS fellowship from Mumbai, certificate course in yoga from Savitribai Phule Pune University, conducted by Kaivalya Dham Yoga Institute, Lonavala. He has won first prize in pain quiz at ICRA Pain, Kolkata. He has done the poster presentation at ISSPCon 2018, Needle Induced Yoga. So I take privilege to invite Dr. Kailash to talk on dry needling. Over to Kailash. Kindly unmute him.
Hello, am I audible to everybody?
Yes.
Yeah.
Yes, Dr. Kailash, you are audible.
Yeah. I would request Dr. Varsha to please start my slides. Yeah. Thanks, Dr. Varsha. I would like to thank both the speakers who have already spoken about the necessary physiology and their own techniques or their methods of doing dry needling. I would be interested in talking about how it works. Next slide. Uh, Brief history of dry needling. Deep dry needling for treating trigger points, first introduced by Czech physician Karel Levitt in 1979. Baldry developed a version called superficial dry needling, in which the needle is inserted about 5 to 10 mm into the tissue above the trigger point. In the 1980s, Changan of Vancouver, Canada, which moved away from using only trigger points. He termed the elicited localized twitch response as the stimulation and call it intramuscular stimulation. Deep dry needling is superior when compared to superficial dry needling in treatment of myofascial pain. Next slide. Basis of dry needling according to Changan's hypothesis was Cannon and Rosenbluth's law of denervation, and also in not according to Changan, but Hilton's law is also important basis for dry needling. Next slide. Next slide, please. Cannon and Rosenbluth recognize 4 types of, this law states when a unit is destroyed in series of efferent neurons and increase irritability to chemical agents develop in isolated structures, the effect being maximal in part directly denervated. Nerves show peripheral and central sensitization, which affects not only sensory nerves but also motor and autonomic nerves. Muscles show increased sensitivity to acetylcholine, leading to spontaneous electrical activity seen as fasciculations or spasm, which generate pain. Next slide. The amplitude, they recognize 4 types of sensitivities. The amplitude of response is unchanged, but the course is prolonged, super duration of response. The threshold for stimulating response is lower than normal, hyperexcitability. Lesson stimuli that do not have to exceed a threshold produce responses of normal amplitude, that is increased susceptibility, and the ability of tissue to respond in augmented is augmented, that is super reactivity. Next slide, please. They also showed that the supersensitivity can occur in many structures of the body, including skeletal muscles, smooth muscles, spinal neurons, sympathetic ganglia, adrenal glands, sweat glands, and brain cells. Furthermore, they showed that denervated structures overreact to many physical inputs, including stretch and pressure. Wherein now here comes the new definition of pain in 2020 by the special. Next slide. ISP new definition states the definition has been changed from an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage, and is expanded upon by addition of 6 keynotes. For a valuable context, next slide. The 6 keynotes include: pain is always a personal experience that is influenced to varying degrees of biological, psychological, and social factors. Pain and nociception are different phenomena. Pain cannot be inferred solely from activity in sensory neurons. Here, only sensory neurons should not be taken for granted. Other receptors, such as stretch receptors, proprioceptors, touch, pressure, all are important. They have further described. Go for the next slide now. Importance was that only sensory neurons are not necessary for pain. Other than those, receptors are also important. Next slide, please. Supersensitivity. Supersensitivity in autonomic pathways increase blood vessel tone of virtually all tissues and cause secondary pain by structural disintegration. Following denervation, the total collagen in soft and skeletal tissues is reduced. Replacement collagen also has fewer crosslinks and is markedly weaker than normal mature collagen. Because collagen provides the strength of ligaments, tendon, cartilage, and bones, it contributes to many degenerative conditions in the weight-bearing and activity-stressed parts of the body: tendinitis, cuff tears, epicondylitis, ruptured tendons, and so forth. Here I want to stress that a degeneration process is normally going on in the body of a person of around around 30 years of age, and this degeneration will lead to all these things. So we have to remember degeneration as a part and parcel of our life, and this affects for the supersensitivity caused. Next slide, please. Nerve degeneration. The two main types of nerve fiber degeneration recognized by them were axonal degeneration, axon that leads to secondary breakdown of myelin sheath, where cause is focal trauma. The term Valerian degeneration is used, and where axonal degeneration occurs due to disease other than trauma, axonal neuropathy is used. Segmental demyelination is patchy breakdown of myelin sheaths limited to individual segments with relative sparing of axis cylinder. Here I want to stress that if we do B12 levels in the patient with chronic pain, I often see patients having more than 2000 picograms of levels of B12 in their blood. It is nothing but the breakdown of myelin sheath which is recognized as B12. Otherwise, the patient is deficient in B12, but it is mistaken as B12 and counted. So the levels are too high. Now, why to initiate treatment with dry needling? It is based on Sunderland's hypothesis, where 5 degrees of injury were there. But I want to stress on 2. In first degree, loss of conductivity of axis cylinders at the site of injury without any grossly apparent break in continuity of structures comprising the nerve trunk, and regeneration is relatively effective. Even when the injury reaches grade 4, when there is damage to the axon, connective tissue, and perineurium, the nerve remains macrobially intact, but regeneration is poorly oriented and less effective. So, initiating treatment with dry needling is a good treatment for patients of chronic pain or any pain. Next slide, please. Why to keep needles for 50 minutes? Usually I do treatments, usually other people do for 20 or 30 minutes, but I keep it for 50 minutes because it is possible that relief is the result of stimulation-induced analgesia, stimulation of the large diameter fibers, or the displacement of nociceptors by fibrotic tissue. Current of injury causes a decline in denervation hypersensitivity And this stimulation applied continuously is reported to be more effective than stimulation applied intermittently. Whenever we do dry needling, the patient feels the pain, and that is the pain is a type of current which he feels, or the trigger point where you hit, it gives pain at a distance point where the other inactive trigger point is initiated by that current. And so continuously giving that for 50 minutes helps to reduce the sessions of the patient for dry needling. So I keep the needles for 50 minutes. Next. Guns radiculopathy model. Dr. Priya has nicely explained this, but still the affected area, dermatome, the myotome and sclerotome, all have to be taken into consideration, wherein the manifestations are vasomotor, skin is cooler, mottling is seen, there is increased sweating, there may be goosebumps, there may be hyperesthesia, neurogenic edema, there may be myalgic hyperalgesia, tenderness over motor points, increased muscle tones, spasms, and swelling and effusions in few cases. Next. Here the figure shows the normal muscles from origin to incision. And now the shortened muscle with palpable, tender, painful bands, they have demonstrated beautifully here. And they have shown that enthesopathic thickened tendons happen towards the attachments. Therefore, the range of motions are reduced unless we reduce the contractions in the muscles which are caused by the MTRPs, or the painful taut bands are released, the patient will not get relief. Shortened muscles means pain, and if the length is restored, then the movements are also restored. Next slide. The shortened paraspinal muscles across an intervertebral disc space can compress the disc and impinge on the nerve root. The above picture shows the normal disc, wherein the nerve root is not affected. But when the muscle gets shortened paraspinal muscles, it compresses the disc and this may impinge the nerve root. Next slide, please. Now coming to Hilton's law. Hilton's law, espoused by John Hilton in a series of medical lectures given in 1862, is the observation that in the study of anatomy, the nerve supplying the muscles extending directly across and acting at a given joint not only supplies the muscle but also innervates the joint. Joint means synonym of the joint and the skin overlying the muscle. Next slide, please. According to Hilton's law, in the spine, if facet joint is having arthropathy, the nerve supplying facet joint will also supply muscles moving the joint and skin over the joint. So affected medial branch irritates the muscle supplied by the medial branch, multifidus and interspinalis, and causes shortening due to spasm, thus generating pain in the affected area. Autonomic changes start to set in the skin, ranging from prophyedema to cutaneous hyperesthesia. Now coming to theories that work, maybe one or all for dry needling. Theory number one, needles in the muscle stimulate sensory cortex in the homunculus, activates thalamus and limbic system, activates for the midbrain and the periaqueductal gray matter, which stimulates the descending inhibitory tracts to release endogenous opiates to decrease pain. Now in chronic pain, what happens is the irritable nerve contracts the muscle Blood vessels compress leads to nutritional deprivation. Muscle cell death leads to fibrosis. Muscle length shortening happens. Vicious cycle continues. Range of motion decreases along with pain. Next slide. After dry needling, needle breaks the fibrosis, elicits a jump sign, and muscle grips the needle. Acetylcholine stores get depleted at the NM junction, loosens grip of the muscle over the needle, relaxation of musculofacial compartment, circulation is restored, substance P is washed out, and pain decreases. Next slide. Also, the needle tip stimulates satellite cells at the basement membrane of the muscle fibrils and helps them to multiply. This is supported by nutritional supply, which was increased due to increase in blood supply containing platelet-derived growth factors. It's like platelet-rich plasma therapy being done within the body. It is my own thinking. Increase in muscle mass restores muscle length and thus decreases pain and increases range of motions. Next slide, please. Now coming to the neuroplasticity concept for dry needling. We all know that pain travels at 2 to 30 meters per second, and proprioception receptors which can stimulate, when stimulated, travels at 120 meters per second. Now, when I do 50-minute stimulation, it is 3000 seconds. So pain travels per second is 30 into 3000. For 50 minutes, it travels for 90 kilometers for one needle. It is for pain. And for other sensation, here I have only considered proprioception. I have not included touch, pressure, or temperature. So 120 into 3000 is 360 kilometers. All this is for one needle. And supposing the human body is only of maximum 2 meters and all are less than about 1.5 or 1.6 or 1.7, 1.8 at max meters, in their body, these circuits are formed continuously, and against 90 and against 90, 360 is 4 times the circuits which they are formed, and that is too faster. So according to gate theory, other sensations win over the pain sensations. So they are able to change or dampen the circuits of brain which were creating the pain. Now here neuroplasticity changes it and helps in reducing pain circuits and decreasing chronic pain. Next slide, please. The new concept here, dry needling stimulates many dormant cortical pathways which are stimulated by proprioceptive and various receptors, leading to sensory feedback, which brings psychophysiological relaxation and pain relief by reducing stress, anxiety, and depression. Now coming to my last slide, almost, here proposed mechanism of ultrasound guided dry needling has been proposed by Dr. Lakshmi Vas, my teacher from Ashirwad Institute of Pain Management and Research. Next slide. Here they have described that ultrasound guided dry needling of myofascial trigger points will lead to elicitation of local twitch reflex in muscle bands by needle entry. After relay of the occurrence of the LTR to the spinal cord, relaxation of muscle occurs. Continuation of muscle relaxation beyond needle removal, possibly due to persistent needle track in the muscle. Reduction and eventual cessation of the continuous spinal sensitization due to loss of nociceptor input, which will lead to pain relief with reduction in opioid medication. Relief and also relief of disability will occur. This is what I had to say about how dry needling works. Rather, the role of dry needling in pain practice have already been described by the previous speakers. I am here to tell you that the first thing which I offer to my patients would be dry needling if the patient considers it. And if he doesn't want any interventions like injections with steroids and does not want any invasive radio frequency treatments, I offer them a non-invasive pulse radio frequency and along with it dry needling, and this has given me very good results. And they the method with which I do and keep it for 50 minutes, the patients don't require the second session in most of the cases. Almost 99% of my patients are cured with one session of my treatment because I keep the needles for double the time of others. This gives very good results. Thanks a lot.
Thank you, Kailash. Yeah, very good presentation. Now topic is open for discussion.
Thank you, ma'am.
If anybody is having a question to 3 speakers, please go ahead.
I have a question to Dr. Priya. Hello, Dr. Priya. I just want to ask her that in CRPS, actually the whole limb is involved, the complete muscle from shoulder joint to the lower end, distal ends are involved. So which muscle do you target in that?
The sessions are being conducted in the form of one day we target flexors, the other day we target the extensors and the neck. So if patient is lying supine, say in case of upper limb CRPS, one day I would target deltoid biceps and flexor aspect of forearm. The next day I would ask the patient to lie down in lateral position. I would target the neck muscles and the extensor aspect.
Okay, got it. Yeah. Thank you. It was wonderful presentation by all the 3 speakers. Great.
Thank you.
Yes, Dr. Kirti, you would like to conclude the session?
Yeah. Should I conclude the session?
Yeah. Any questions or any comments? You could see in the chat box. Okay, nothing as of now. Okay. Concluding remark on the session, please.
Yeah, okay. So finally, it was great presentation by each of the speaker. It will definitely help each and every pain practitioner. In present era, being pain physicians, we need to think beyond MRI, CT scan and nerve conduction study. Luckily, musculoskeletal ultrasonography and elastography have been emerged as promising diagnostic modalities for muscles. Ultrasound shows heterogeneous hyperechoic muscles, muscle fibrosis, and altered microvascular flow on Doppler, while elastography shows stiffness of particular muscles. So these two diagnostic tools are and will be the choice of investigations in near future of pain practice, as each of it talks about culprit muscles as a reason for chronicity of pain. And this is the reason why we should learn scientifically about dry needling, because dry needling is and will be the integral part of pain management. Thank you very much.
Okay. Thank you, Dr. Kirti. I could see many comments, scrolling through the chat box, and everyone is so eager to learn more about dry needling. Already few are practicing, and this session has given such a good insight to newer aspect of hypodermic needling by Rajeev Harshe sir, and dry needling by our own Priya and Kailash. So now I would like to end the session with Thanksgiving. So thanks to all speakers for excellent insight and presentations, and most importantly, following timeline. So it was, very much within reach of every speaker and organizers, keeping it compact at the same time giving full information. That was wonderful part of it. Moderator Dr. Kirti Pawar, madam, thanks a lot taking out time from your busy schedule. I would like to thank for this platform, online Zoom platform by Society for Study of Pain, Pune, and Anaesthesia TV, who has taken this session live on 5 platforms at a time. So it is really commendable job on their behalf. And our SSPP team, who is managing technical aspect as well as, getting the flyer done and all the formalities, Dr. Vivek, Dr. Sanjog, Dr. Varshali. So I would really like to thank my SSPP academic wing. And last but not the least, our ever enthusiastic audience, giving wholehearted comments and appreciation and initiating discussion with nice inputs and questions. So I would like to conclude the meeting here. And every
Varsha, I would like to say
yes,
something.
sir, please. Yes, sir, please.
First of all, excellent way of conducting the whole session, right? Crisp, time to time. Now this is 9:26 in my mobile. 9:30 I'll be with my dinner. So fantastic. I mean, the commendable job. And the topics were good. Speakers were naturally everybody shared very nicely, and audience was good, interactive, and 100 marks to you for nice initiative. I mean, Pain Society conducting regular Zoom meetings or virtual meetings is something required. And in coming days, I hope you will take more and more new topics to come up on the stage. Those who are interested in hypodermic needling, you may ask them to register with you. Whenever I plan out a camp, one-day session, I'll let you know.
Right,
Right?
sir, definitely.
Thank you very much for inviting me. Thanks a lot.
Thank you, sir. Okay, good night, everyone.
Good
Priya, can
night.
you stop the recording now?
Recording stopped.
Okay, now you'll get the option to upload it on cloud. Okay, so the recording will be uploaded.